blood gas analysis, in fact. So, this is a pretty common thing which we all keep on coming across. Uh, and these are the topics and the subheadlines under which we will be speaking one after the other. And there will be some examples as well for which we'll try to further try to get an answer as well. So, some of the reasons we all are very much aware that a lot of things, yes, we are trying to do a blood gas analysis to know a few more things, but there are a lot of things as well without that, without doing the specific test as well, we can know. So, what are they? Like the history. So, for example, we need to be asking, is the patient is having any difficulty in breathing? Then, how has been the changes in the symptoms over passage of time? Then, what about those physical symptoms? So, for example, whether the is it related, the patient's breathing is related to the work. So, for example, dyspnea on exertion. So, similarly, is it associated with any wheezing? And then you can even further try to see as well on the physical examination, is it related with rails as well? So not always invasive you have to go. So there are non-invasive things as well. So what about the one of the best tools, what I call it as the fifth vital sign. So that is the, any guesses what is it? The pulse oximetry. Very simple, very handy, awesome tool in fact. So this is not only non-invasive, instantaneous, you are able to get the result, ubiquitous, and also you will be able to know, we all are aware the oxygen saturation less than 95% is the one which is usual cutoff in fact, but being a wonderful tool, it has its own limitations as well, that yes, there should be good volume pulse in fact, and only when there is significant decrease, then it will be able to detect in fact. And yes, it does not give a comment about the content. And that is the reason why we try to do the sample arterial blood gas analysis. So, what is the reason for that? Because we want to be firmly establish the severity of oxygenation abnormality. In fact, we also want to evaluate, is it hyper or hypoventilation. Similarly, that if currently there is no convenient non-invasive way of evaluating PCO2 as well, unfortunately but true, non-invasive way, and so easy way, it's difficult, we don't have. And the other reasons why we are trying to do this test is of course to determine the acid base status, especially in a patient who is having like a metabolic acidosis, for example, for diabetic ketoacidosis, and of course also to track the application of mechanical ventilation in a critically ill patient. So how is that critically ill patient is doing? But there's a big question mark over here. What is it? Most dyspneic patients don't require ABG analysis. Do you know why? So the answer I'm already giving you. Because when the cause of dyspnea is established, so for example, if it is due to asthma, CHF is there, restrictive lung disease is there, why do you need a ABG? Of course not. Similarly, when a cause of dyspnea is suspected and the patient is not specially ill, for example, if there is a child with new onset wheezing in January, do you need to do that? I don't think so. Similarly, when the dyspnea is so severe as to warrant immediate mechanical ventilation, so the decision is, of course, to intubate, mechanically ventilate. In fact, okay, it has been already been decided upon the clinical. Yeah, so like every wonderful thing, ABG also has its limitations. Limitations in the sense ABGs measure only the partial pressure, which is the tension. So that's why one of the key things which we all should keep in our mind is PO2 is not as the content. Okay, let's try to give you an example. If there is a severely anemic patient, may have a oxygen content which is reduced by half. while maintaining perfectly acceptable gas exchange, and of course, they're for maintaining a good PO2 as well. But is that normal or abnormal? That's what we need to think. Similarly, yeah, I don't like to take needles on my body, so it definitely hurts the patient as well. So, in fact, what about if you do the sampling from a vein by mistake, and if a patient is hypotensive, it can be difficult. Similarly, complications can happen, like the arterial thrombosis, but yeah, those things can happen. So that's why we all have to be careful. So, what is the definition? So, this is the test in which the blood is being obtained, of course, from the artery directly by an arterial puncture, otherwise, even from an indwelling arterial catheter. So, this is what I think most of the people can recall very well. And regarding the indications, as I had already said it, if you're trying to obtain the information about the patient ventilation, PCO2, oxygenation, then acid base balance, or similarly, you want to see about the monitor, gas exchange, and the acid base abnormalities. Then, if you want to evaluate the response to clinical intervention and diagnostic evaluation as well, for example, oxygen therapy, similarly, it's really, really useful when the patient's breathing rate is increased or decreased. And yes, if the blood sugar levels are very um, deranged, there's a severe infection, or even associated heart failure as well. So ABG has different components as well. Components like the pH. pH refers to the, it tends to measure the hydrogen ion concentration in the blood, and it shows the blood acidity and alkalinity, right? Then comes the PCO2. So PCO2 is the partial pressure of a carbon dioxide that is carried by the blood for excretion by the lungs, known as respiratory parameter. Then comes is the PO2. This is the partial pressure of oxygen that is dissolved in the blood, and it reflects the body's ability to pick up oxygen from the lungs. Okay. Similarly, then comes the bicarbonate. Bicarbonate is known as the metabolic parameter. It reflects the kidney's ability to retain and excrete carbonate, in fact. So once we know, what about the normal values? We all are very much, I think all the audience members are very smart enough. They know for the pH, 7.35 to 45, PCO2, 35 to 45. So that's what I try to recall, 7.35 to 7.45 and 35 to 45. Huh? That makes it easier for us, right? Oxygen, of course, 80 to 100. Then comes is the bicarb. So bicarb, to make it a little easier to remember, is slightly lesser than the PCO2. Okay, this is CO2, CO3. So the numbers are lesser over here, 22 to 28. These are the memory aids I always try to tell, because of course initial days we know we need all these memory aids to put it in our mind, but of course later on, as you keep on seeing it often and more often, so it is going to be there in your permanent memory and you'll never forget. Okay, so what about the equipments? You need a blood gas kit. What does it contain? So it contains a 1 ml syringe, there's a 23 to 26 gauge needle, there's a stopper or cap, there's alcohol swab, there's disposable gloves, plastic bag or and crushed ice. Lidocaine may be optional. Similarly, a vial of heparin, 1 is to 1000 dilution, or even a label or a barcode. So we know about the blood casket. So there are different phases in which this is being performed. So first phase is called as the preparatory phase. Why do we call it as preparatory phase? So in that, you're trying to record the patient's inspired oxygen concentration first of all, check for the patient's temperature. You must explain the procedure to the patient, take a informed a well written consent as well, and yes, ensure for the privacy of the patient, and heparinize the needle if you're not using a heparinized needle, in fact. And you must do a very important something is called as Allen's test. So, and you should wait at least 20 minutes before drawing blood for ABG after initiating, changing, or discontinuing therapy, in fact. Even for mechanical ventilation as well, if you have done the suction or extubation, so at least 20 minutes it should be there. 20 minutes is a very important thing. So, what is Allen's test? Does anyone remember? Let me try to show you some bigger. Okay, does this remind of something? So, what is being done is Allen's test is actually a test which is done to determine that collateral circulation is present from the ulnar artery in case thrombosis occurs in the radial. So, this is a wonderful test and it should be done ideally before a ABG. So, if you look carefully in this figure, so what you do is uh, you try to induce the pallor by clenching, okay, by seeing this alternate occlusions, okay, and that's why it is very, very important, as I said it, because you are trying to see if there is a collateral circulation is present. Yeah. So, what are the different sites? There are different sites. I can go to the radial artery, brachial artery, or even a femoral artery. So, but radial artery is the most common, and so this is what you may recall a lot of people when it is being taken from the different sites. But why radial artery is the most common site? Would anyone like to tell me? Why not brachial artery? Anyone? No one wants to try. Come on. Please use the chat box. Hmm. There's a good number of students who are present. So why you want to do in radial artery is because of the ease of access. It's not a deep artery, which facilitates palpation, stabilizing, and even puncturing. And similarly, because the radial artery is the one which also has collateral blood circulation as well. So this is the reason. Now coming to the next phase. So what we initially spoke about is preparatory phase. Yeah, preparatory phase. After the preparatory phase, this is called as the performance phase. In performance phase, what do? You have to perform. Perform means you have to wash hands, put on gloves, palpate the artery, where you feel the maximum pulsation. If it is radial, of course, you must do the Allen's test. And then put a small towel roll under the patient's wrist. This is very important because you want the patient to be comfortable as well. And ask the gentleman or the person to breathe normally during the test and warn him the person may feel a little bit of throbbing pain or even cramping at the puncture site, in fact. And then you may clean the alcohol swab in circular motion. And finally, skin and subcutaneous tissue may be infiltrated with local anesthetic agent. So, this is what I think we all can recall very well, those moments, okay? So, what do you do? So, then comes the follow up phase. So, what do you do? So, what do you do over here? So, you have to insert this needle 45 degrees, okay, for the radial. For the brachial, it is how much? 60 degrees. And for the femoral, it is 90 degrees. 45 degrees, 60 degrees, and 90 degrees, okay? Radial 45, brachial 60, and femoral at 90 degree. Then you have to withdraw the needle, apply digital pressure, check for bubbles in the syringe, and then place the capped syringe in the container of ice immediately. And you must apply a firm pressure on the puncture site at least for 5 minutes. And yes, if there are some Coagulation abnormalities, at least 10 to 15 minutes. So then comes the follow up phase. So, what do you do in the follow up phase? You send that specimen to the lab immediately and you must palpate for the pulse distal, not proximal, distal, distal to the puncture site. You have to see for the cold hands, numbness, tingliness, or even discoloration. And you must document few things. What would be the results of Allen's test, the time when the sample was drawn, temperature, puncture site, and the time. How long did you apply the time pressure as well, and if oxygen therapy is there. Um, See, I'm also telling all these things. Why? Because I know in several countries it may not monitor, it may not matter the documentation part and all, but in most of the Western countries and all, it can be a big trouble otherwise. Like if you're in UK, US, or if any of these, if you don't follow these documentation things, you can be screwed. You can be put into litigation easily. So that's why I mean to say is always inculcate the habit of documentation. And that's very important. And as I said it already, you must make sure that, you know, and it's noted on the slip whether, the patient is on room air or oxygen, in fact. And similarly, then uh, the number of liters of oxygen, how much liters of oxygen the patient is on. Similarly, if the patient is on mechanical ventilation, how much is the FiO2 the patient is taking. So, being an invasive test, it has its complications as well. So, what are the complications includes is, of course, the spasm, which can happen at the local site, hematoma, hemorrhage, distal ischemia, infection, even numbness, of course, as well. Okay, now we are done with the procedure. Now let's try to look at those numbers. Okay, so our body always is at homeostasis. The process is there going on, going on. So what happens is, if you want the cells to function properly, because the cells are the ones which need the nutrient to be able to give you the ATPs. Okay, so the byproducts, there are two main byproducts which is formed, H plus and CO2. So to maintain the acid base balance, these regulation of free hydrogen ions is very important, in fact. So that is why if there is slightly imbalance as well between this, it can not only affect the metabolism but also the essential body functions as well. And there are several conditions, for example, like infection, trauma, medications, which can affect this balance, in fact. So let's try to get a little bit of understanding of these numbers. So as I had already said it about the normal pH values is 7.35 to 7.45, okay? And for this PCO2 it was 35 to 45 and bicarb was 22 to 28. You all are forgetting it so soon. Okay, now let's, okay, if the pH is 7.30, so this is of course acidemic. Then PCO2, if it is PCO2 is 55, so it is higher, right? So if it is increased this, what will be the reason? So it will be most likely respiratory cause, right? Then similarly for the bicarbonate, as I was telling you, 22 to 28, right? So 25 is normal or abnormal. So this is in normal range. So what do you think? So what this is? Hmm? Respiratory and acidosis. So pH is acidic and PCO2, as you saw, it is increased. So respiratory, due to respiratory cause, it is causing acidemia. So you will be calling it as respiratory acidosis. And yes, oxygen is normal over here. Okay, shall we try to even have a brief overview? One more example. Okay, 7.49. 7.49, of course, is alkali. Sorry. PCO2. So PCO2 is 40. So this is normal. Then what else will you look for? Bicarb. So bicarb you are trying to look is 29. So this is slightly on the higher side. So higher side means this is increased. So what is the reason? Metabolic cause, of course. Yeah. Now we try to look further at the PO2, 85, which is normal. So this is what is. So what is this picture? This is metabolic alkalosis. Hmm. So I think you all are already now the masters. So let me try to give you some tips and tricks. Tips and tricks will be is, so what are those disorders? So disorders is like respiratory acidosis. In respiratory acidosis, if you look carefully, so the pH will be down, of course, because it is acidosis, right? Then PCO2 is going to be higher. That's how the respiratory cause will be there. Then comes respiratory alkalosis. Dr. Prasad, please mute your microphone. Uh, okay, respiratory alkalosis. So, respiratory alkalosis, what happens is this is alkalosis. So, the pH is going to be higher, of course, more than 7.45. The PCO2, the PCO2 is going to be lower because it is respiratory. And of course, bicarbonate is going to be normal. Then when it comes to metabolic acidosis, similarly the pH is going to be lesser, but PCO2 is going to be normal. However, the bicarbonate is going to be down, and that's why it will be metabolic. No metabolic alkalosis. So the pH is going to be more like alkalosis, PCO2 unaffected, and the metabolic component, which is determined by the bicarbonate, is going to be elevated. So there is a phenomenon, if this imbalance or this problem has been going on for a little bit longer time, compensation phenomenon of compensation will start to happen. So during compensation, what happens is the respiratory and metabolic system works together to keep the body's ACE-base, acid-base balance within normal limits, in fact. And the respiratory system responds to metabolic base pH imbalances in the following manner. So, what happens, as I was telling you, in cases of metabolic acidosis? So, metabolic acidosis, as I had said, what will happen is pH will be acidic and metabolic component will be reflected by the bicarbonate. So, there will be, what is the compensation going to happen? In the compensation is going to happen is it will increase the respiratory rate and also the depth. So, therefore, PaCO2 is going to be decreased. Then for the metabolic alkalosis, so if you will remember, the pH is of course going to be alkaline, so higher than 7.45. But if you look at the bicarbonate levels, they will be favoring this. So that is why the compensation is going to be opposite of the metabolic acidosis, which is decreased respiratory rate and also the depth, so which is going to increase the PaCO2 in fact. And then the metabolic system responds to the respiratory based pH imbalances in the following manner. So, as I had said it earlier, so this becomes a little bit opposite in the sense, for example, for respiratory acidosis. So, what is happening over here is, so if you look carefully, this is acidosis, right? So, pH is going to be less, bicarbonates will be normal, but the PaCO2 is going to be altered and favoring the respiratory. So, therefore, the bicarbonate is going to be increased, resorption is going to be there, right? And the opposite things happens for the respiratory alkalosis. So I think you already understood the concept of compensation. Okay, I'll give you some practical examples. So what is happening? For example, this is the respiratory acidosis. Respiratory acidosis is in initial stages. As I said, acidosis, the pH is going to be down. because 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 if it is going to be respiratory, so of course the CO2b is going to be higher, and the bicarbonate component is going to be lower. It's not unaffected. So that is what is the uncompensated phase. Because of lack of response from the kidney yet to acidosis, so the bicarbonate will remain normal. However, so what is that is where comes the partial compensation. Partial compensation is going to be, for example, respiratory acidosis. What did I say? So the pH is going to be acidotic. But when you look at the carbon dioxide component, carbon dioxide, of course, is going to be increased. However, and in response to that, because it is trying to compensate, so that is why bicarbonate will also increase further, in fact. So what is the responses? Because in the compensation, as I had already mentioned, kidney is starting to respond to the acidosis by increasing the amount of circulating bicarbonate. Okay, and what is the fully compensated? So the fully compensated one, what is going to happen is, in fact, the pH is going to become normal. PaCO2 is still going to be elevated, and the bicarbonate is also going to be elevated. So during passage of time, so it takes time a little bit when this will is going to happen, of course. Yeah. In the last stage, as I said it, so the pH is going to become normal, but because it was corrected, so that's why due to the compensation mechanism it has happened. So the PaCO2 and the bicarbonate is going to be higher. So similarly, what is happening in respiratory alkalosis? So as I said, it respiratory, it is alkalosis. So pH is going to be higher, PaCO2b is going to be lower, bicarbonate is not going to be affected in the uncompensated. So the kidney is still going to be recruited, in fact. And the partial compensation, what is going to happen is bicarbonates will start getting decreased. When the bicarbonate is going to start decreasing, so that is the partial compensation, and they continue to decrease further so much up to when the pH becomes normal. Then it means is fully compensated. So if you understood that, so this is the reverse of that. So this is what is called as a metabolic acidosis and metabolic alkalosis. So metabolic acidosis, what happens is in the uncompensated one or the normal one, the pH will be less. PaCO2 may be normal, of course, without getting affected, but the bicarbonate is going to be lower. So this will be the uncompensated. So the lungs, there is not yet any response from them, in fact. So that is why once they will be recruited, they will start to decrease the amount of circulating carbon dioxide. So in the partial compensated stage. However, in the fully compensated stage, the pH will also become normal and the PCO2 or bicarbonate are going to be lower values. So the fourth stage, what is going to be is the metabolic alkalosis. So metabolic alkalosis is in the uncompensated stage. Anyone would like to take a chance to explain this? Any of the students? So what is happening over here? Pankaj, try.
Sir. pH is increasing, that's why it's alkalosis,
Wonderful.
and HCO3 is increases. That means it's a metabolic alkalosis.
So how much is the
And
normal? How much
PSCO2
is the normal value of bicarbonate?
is 22 to 28, sir.
Wonderful. Okay, so in the partial compensated,
Partial compensated, sir, pH is increased,
hmm.
and that means it's alkalosis still.
Mhm.
HCO3 is also increased. That means it's a metabolic alkalosis. In response to the alkalosis, the lung responded and causes the PaCO2 to increase, uh, so that
Yes,
hello.
that's the way. Wonderful, wonderful. So now what is happening in the last stage?
In fully compensated, it is normal pH,
Hmm.
and the pH is normal, so that's why it's compensated fully,
Hmm.
and the PCO2 and HCO3 is
So
increasing.
what was happening in the metabolic? So this becomes the last stage when the partial compensation starts. Partial compensation, how it starts is the PCO2. When the next ABG you will be doing, so you will notice the PSCO2 is going to rise. However, when you did, for example, again after a few hours, you did the ABG again. So what is going to happen is you'll be surprised in the same patient. Oh my gosh, the bicarbonate, which was higher, okay, it is still high, but PCA2 also has become higher, but the pH has become normal. So that is what is the stage of full compensation, in fact. Yeah. So
Okay.
the pH. So in the initial stage, the counterpart is the key to look out for. For example, if it was metabolic acidosis in alkalosis, in which you were trying to look at the bicarb, you have to look at the PaCO2. And if you are able to look on that, and later on, if you see the normalization of the pH, bingo, you are done. Okay, seeing solving problems is one of the really, really important things, especially in this. So, we are trying to give you some examples. Try to think about this clinical case scenario. Okay, you all have to work it out now. I'm going to speak less.
Respiratory alkalosis.
And what about others? Please use the chat box. Okay, now since you all have already become masters, now I'll make you a real expert. Real expert is you are knowing your diagnosis. Now, my next question. Next, please use the chat box. Okay, Azad has written respiratory alkalosis. Everyone, please use the chat box. Do you know what is the formula to say if it is acute or chronic? I'm going to teach you that as well. Now, I'm going to take you even beyond your consultant. Consultants will be saying, oh my gosh, this guy is able to tell about whether it is acute or chronic. So, I'm going to teach you that as well. So, I think you already went through the pH. So, pH is lower or higher? pH is higher, yes. So, this is acidosis or alkalosis? Alkalosis. Okay. So, and then PCO2 is normal or higher? So, how much is the normal value? Oh my gosh.
35 to 45.
Yes, exactly. So, PCO2 is lower or higher?
Lower.
Everyone agrees? Wonderful. And the PO2 over here?
Lower.
Right. So, what do you think so far now? So, this is alkalosis for sure, by looking at the pH. And by looking at the PCO2? Wonderful. You all are so smart. Okay. Now, the next level of question. So, you have all these values. Yeah. So, you already know now the answer for this. Now, the next question I'm going to put is whether it is acute or chronic. How are you going to calculate? So, this is the formula. This is the formula if you want to use. So, for example, what happens is if it is acute, the pH change will be 0.08 times into 40 minus PCO2 divided by 10. I would really like you all to know this formula because this formula is really, really important. So, in this, if you are going to put up the value of PCO2, blah, 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 for a pH of 7.49, yeah. So, how much it is coming? And yes, if it will be 0.09, otherwise if it is going to be chronic, then 0.03 into this. Okay, you should be doing it like this. So then you get a pH of 7.43 or 7.49. But we already can see the pH. So what is the pH is 7.48.
48. So it
So
is acute.
absolutely, you all are the masters. You all are so smart. Okay? So if you have just three values, you will be able to know whether it is acute or chronic as well. Don't forget this formula: 0.08 for the acute, 0.03 if it will be chronic. 40 minus PCO2 divided by 10. And you calculate the pH with this, and as you calculate the pH, you will be able to see it is acute or chronic. Yes? Okay, one more example. So what do we notice in this, the pH? Acido.
It is alkalosis.
Oh my gosh, everyone is now so smart now. And the PCO2?
Is it decreased?
Wonderful, wonderful. And O2?
That is also on lower side.
Wonderful. So this is,
Respiratory alkalosis.
and what is the reason for
Yes,
that is? The reason is hypoxia. Okay,
hypo.
so now since we have finished one example, let's try to go to the second example. A
The
47,
pH is normal.
yes, first read the history as well, my friend. What did I say to you? There are few things you can do without the ABG as well. So history is also, you are a doctor. You're going to be a cardiologist. So you should be able to understand, first of all, what is the importance of history. History is very, very important. Yeah? So let's try to be
Okay.
clinicians. So 47-year-old woman with a history of 65 pack per year tobacco use is being evaluated for disability due to dyspnea. She comes to the ER, you are there, okay, and you see this patient. You did a ABG, and this is what you obtained. So pH is 7.36. So is it normal, abnormal?
This is normal, but we can evaluate as a COPD patient.
Okay, okay. I can see there are two people trying to speak. Okay, pH is normal. Then what about the PCO2? Okay, I'm already getting some answers as well. So PCO2 is 54, right? And the PO2 is 62 over here. So let's try to be, first of all, very smart guys. Let's try to see whether it is acute or chronic. Ah, I'm already getting some smart people answers as well. Conflicting answers. Okay, let's try to find it out in the meantime. So what is the gradient difference? So gradient difference, I had already shown you the formula last time. So in that is for the acute and for the chronic. So, so with the 0.08 and with the 0.03, what is the pH you get is? So the pH, as we could already see, 7.36. So this is definitely a chronic case, yeah? So we are able, yes. So now, yes, so we were already having the other values as well. So this is definitely a chronic but respiratory acidosis. Acidosis, why did we say it? Now you have to tell me. Tell. So what has happened is this is, since this is a chronic
So
case.
it is towards the acidotic side, pH.
Yes, yes. And what has happened is due to the compensation has also happened, in fact, in this. Okay, so that is why chronic respiratory acidosis, and both are hypoventilatory and primary oxygenation abnormality, in fact. Okay, since you have understood this, I'll try to give you a little bit different style of question. Let's do one more example. Okay, says there's a patient of 32-year-old, 32-year male, okay, to the nursing unit with a severe asthma attack. and the patient, हाँ जी बाकी है please आप mute your microphone please, and the patient has been experiencing increasing shortness of breath since admission, which was 3 hours ago. You, uncle ji, auntie ji, please mute your microphone. And then you did the ABG. So you got it now? So what do you notice in this lab picture? 7 point. Vikas Singh, please. Vikas Singh, please mute your microphone. Who is it? Please mute your microphone. Don't disturb others during the lecture. Hmm. So,
It is acidosis.
mhm.
Respiratory acidosis.
Hmm. What about the first?
PaCO2 is increased.
Okay. So what about the? So we all remember. Hmm? We saw that pH is low, so therefore it is acidosis. We saw the CO2, it is high, right?
Yes.
So it is high, of course, but in the opposite direction. So then we try to see for the bicarb. Bicarb, when we notice it, it is in the normal range, right? And
Yes.
acidosis is present because of the decreased pH with PaCO2 being increased. So what it reflects is primary respiratory problem. And for this patient, in fact, we need to improve the ventilation status by providing oxygen therapy or even mechanical ventilation. If you want, you can even give some bronchodilators, okay? Because as I said it, you are a doctor as well, so you have to treat the cause. You're not just technician, like you just have to yeah, just diagnose. No, you should be able to treat the patient, help that patient's quality as well, right? Hmm. So one more example. Let's make you the real masters. So there's a 35-year-old female patient admitted with recurrent bowel obstruction, and the patient is having intractable vomiting. So there's some hint already in the last several hours. So you did ECG, and then what is the so this is what you notice. So now you have to.
It is metabolic alkalosis.
Oh my gosh, my audience, my kids have become really, really smart now. Hmm? Very, very nice. Okay, is it now? Okay, let me give you the twist. Is it acute or chronic? Anyone else?
No, it's chronic because according to history is recurring bowel obstruction and vomiting from last several hours.
Calculate the
So
pH. It is simple. Use your pen and papers. Let's see others.
that can be acute.
So, come on, you know this is not you don't have to guess. You have to do the calculation and you will know the answer. Isn't it? So, so you all can, and now it's not such a difficult and complicated thing as well. You all can sit together. I mean, take your time uh, and do it. Yeah. So we saw at the pH, and pH is of course higher. So it is alkalosis. You saw at the CO2, it is in normal range, but the bicarbonate is high. So this is Metabolic.
alkalosis.
Yes, exactly. And what are you going to treat it with? Treatment, I think we can talk more in details, but on an overall basis, you have to try to treat for the excess space. And the thing, as I had already said, it is, yeah, being in the wards or in the exams as well, one of the key things is practice, practice, practice. There are some softwares as well, which is there in your apps or mobiles. You can use it in a smart way. And one of the important things is you should try to always think as well. What about, why the patient is not breathing well, and is there some dual pathology, like is there respiratory, metabolic disease as well, both of them together, in fact. So there's already a algorithm from ARC, Australian Resuscitation Council. So the five-step approach, what it says is, uh, you have to do is there's a five-step approach. So for example, the first one is, of course, how is the patient? So how is the patient? That's why we all are clinicians, healthcare professionals. So it is going to give you a clue for the interpretation of the results, in fact. And then you try to assess for the oxygenation. Is the patient hypoxemic? If the PaO2 should be more than 75 mm of mercury breathing air, similarly, then you have to do some bedside calculation in the sense like the percentage of inspired concentration multiplied by 5 times. It should be at least within 75 millimeters of mercury. Then comes is the pH, acidic, alkalic. Then comes the respiratory component. On the basis of this, whether it is respiratory acidosis, alkalosis. Then, uh, as we spoke about, is the metabolic component. If it is less than 22 or more than 26 or 28, for so so to summarize, how is the patient? You have to see for the oxygenation, then the pH, respiratory, or the metabolic component. So I'll give you one more example. Practice makes a doctor, I would say, more perfect, right? So you are called up by the staff. There's one 21-year-old woman which is on the way, is becoming drowsy, in fact. The lady was thrown off her horse at a local event. So, so what are the things that should be done is A, B, C, D, E. So the uh, clearing was done to tolerate, and the patient is able to tolerate a oropharyngeal mask. So 40% of oxygen is being given. Then respiratory rate is like 8 beats per minute, in fact. You try to see the SpO2 is like almost 99%. Good air entry, both sides. Pulse is 54 beats per minute. Blood pressure is pretty good, but slightly on the higher side. ABG was done. Okay. Check the blood glucose level as well. Normal. IV in the right arm has been put up. In fact, the eyes are slightly swollen. Bruising is present. And now the doctor is being called. So this is a specialist protocol. If you will be practicing medicine, and especially in the ER, this is how you have to put up everything. So practicing in Australia is not easy. Okay, so a lot of people I know, you all would like to go and be there. In fact, in future, so you have to follow more and more protocols, especially in any of these Western countries. So this is a typical example in Australia. That's why this is an example from ARC. Hmm. So the first of the five steps in ABG is, as we already said it, how is the patient? You have to do the ABCD examination, assessment, in fact, for the patient. So we already spoke about the ABCD examination, huh? Over here, as you can see, ABCD is what? Airway, breathing, circulation, D for glue,
Circulation.
and E for axis. ABCDE. And don't forget that airway, breathing, circulation, glucose, drugs, drugs actually, E for axis. Okay, you did the ABG. Oh, the answers are already here. So, but try to think logically. What is happening over here? So you got the values over here. So the pH is on the lower.
Acidic side, yes.
Right, right. Acidic side. Then after that, what do you see after pH?
PCO2 is a higher side.
Increase, higher side.
Wonderful. PCO2 is like more than 78, in fact. 78. So 35 to 45, that's what I was knowing was normal. And similarly, oxygen is also on the higher side. However, when we look at the bicarbonate is within normal. Now the trick comes. So, what is it?
Preparatory acidosis.
Hmm? Good. Good. So you all are already now the masters. So now I need not teach anymore. You all are very well knowing, in fact. And yes, because the other thing was acute or chronic, right? You all did not calculate it. You all are forgetting it. Don't forget, acute or chronic as well. You should be able to say, because if it is chronic, for example, like COPD and all, the mechanism you're going to deal with in a different way, right? Similarly, if it is acute bronchial asthma attack, you're going to again deal in a different way, right? So that's why it is definitely, I would really suggest you all to develop a habit of calculating